Hello friends, today we are going to discuss this case of central line related bloodstream infection and the treatment of it. So we have this patient who is 77-year-old female patient who is a known case of diabetes mellitus, hypertension, OSA, COPD, CKD on maintenance dialysis. This patient has the permacath in C2. Now she came with a fever, breathing difficulty. Her blood culture showed Enterococcus faecalis. So in view of suspicion of central line related bloodstream infection, the permacath was removed. And we have started our empirically on the meropenem teicoplanin to cover as well as to cover gram negative as well as gram positive bacteria and other supportive treatment. This is the ECG and the echo of this patient. Now we will have the brief discussion on central line related bloodstream infection. So it is a clinical definition of bloodstream infection where infection is attributed to the intravascular catheter by means of quantitative culture of the catheter tip or by the differential time to positivity between the catheter and the peripheral venipuncture specimen. So CLABSI. So what is a CLABSI? So CLABSI, it is an infection when eligible bloodstream infection organism is identified and the eligible central line in patient is present within 48 hours of period before development of bloodstream infection. So so when to suspect this CRBSI? So CRBSI should be suspected when there is a fever or rigor occur within 30 to 60 minutes of starting or occasionally disconnecting a parenteral support infusion. So patient can also present with non-specific malaise or as fever episode, including endocarditis, septic pulmonary emboli, descitis or osteomyelitis with raised blood inflammatory markers. Now, the central venous CRBSIs, these are the significant cause of morbidity and mortality in patients requiring home parenteral support, while infection can arise from the infusate, catheter exit site, or hematogenous spread from another source. The infection is most commonly derived from a catheter hub. Organism from the catheter hub spread down the inner surface of the catheter, forming adherent biofilm. When there is a flow within the catheter, these organisms enter the circulation. The infected biofilm may be associated with the thrombosis at the end of catheter, and the organism may extend into the outer surface of the catheter within the fibrin channel. Microorganisms most commonly encountered in the CRBSI in whom parenteral solution patient are Coagulase negative staphylococci, gram negative bacilli, gram positive bacteria including Staphylococcus aureus and Candida species. Around 10% of episodes are due to infection with multiple organisms. Now, how are we supposed to diagnose it? So, catheter culture should be performed when catheter is removed for suspected catheter-related bloodstream infection, and catheter culture should not be obtained routinely. Quantitative broth culture of the catheter tip is not recommended. And for central venous catheters, catheter tip should be cultured rather than subcutaneous segment. So for culture of anti-infective catheter tip, use of specific inhibitors in culture media should be done. So when are we supposed to call it as central line related bloodstream infection? When there is a growth of more than 15 colony forming units from 5 centimeter segment of the catheter tip by semi-quantitative culture or growth of more than 10 raised to 2 colony forming unit from catheter by quantitative broth culture reflects catheter colonization. When catheter infection is suspected and there is a catheter exit site exuded, swab the drainage to collect specimen for culture and gram stain. Now, short-term catheter including arterial catheter. For short-term catheter tip culture, the roll plate technique is recommended for routine clinical microbiological analysis. For suspected pulmonary artery catheter infection, culture the introducer. For long-term catheters, semi-quantitative growth of less than 15 colony forming unit per plate of same microbe from both the insertion site culture and catheter hub culture, it strongly suggests that catheter is not source of bloodstream infection. If venous access subcutaneous port is removed for suspected CRBSI, send the port for microbiology lab for quantitative culture of the port reservoir content in addition to the catheter tip. For the diagnosis, blood culture. Obtain sample for the blood culture prior to the initiation of antibiotic therapy. When available, phlebotomy team should draw the blood sample. Skin preparation for obtaining percutaneously drawn blood sample should be performed carefully with the use of either alcohol tincture iodine or alcohol chlorhexidine rather than povidone iodine, and allow adequate skin contact and drying times to mitigate blood culture contamination. If blood sample is obtained through catheter, clean the catheter hub with either alcohol tincture iodine or alcohol chlorhexidine, allowing adequate drying time to mitigate the blood culture contamination. For suspected CRBSI, paired blood sample drawn from the catheter as well as from the peripheral vein should be cultured before initiation of antimicrobial therapy. The bottle should be appropriately marked to reflect the site from which samples were withdrawn. If blood sample cannot be drawn from the peripheral vein, it is recommended that two blood samples should be drawn through different catheter lumen. It is unclear whether blood culture should be drawn through all catheter lumen in such circumstances. So the definitive diagnosis of CRBSI requires the same organism grow from at least one percutaneous blood culture and from culture of catheter tip, so that two blood samples be drawn from one from catheter hub and one from the peripheral vein that when cultured meet the CRBSI criteria uh, for quantitative blood culture or differential time to positivity. Alternatively, two quantitative blood culture of samples obtained through the two catheter lumen, in which colony count for a blood sample drawn through one lumen is at least threefold greater than colony count for blood sample drawn from the second lumen, should be considered to indicate possible CRBS. For quantitative blood culture, colony count of microbe grown from the blood obtained through catheter hub is at least threefold greater than the colony count from blood obtained from the peripheral vein. Best defines CRBC. For differential time of the positivity, the growth of microbe from the blood sample drawn from catheter hub at least 2 hours before microbial growth is detected in blood sample obtained from the peripheral vein. Best defines CRBSI. Then quantitative blood culture or differential time positivity should be performed before initiating antimicrobial therapy and with same volume of the blood per bottle. Evidence is insufficient to recommend that blood culture be routinely performed after discontinuation of antimicrobial therapy for CRBSI. So cardiac echo, so transthoracic or transesophageal should be performed in any patient with prosthetic heart valve, pacemaker or ICD, and persistent bacteremia or pyrexia 72 hours after initiation of appropriate antibiotic therapy, and also performed if there is Staphylococcus aureus infection. If back pain is present, spinal MRI should be considered. If there is fungal infection, then go for the ophthalmological reference for thorough ophthalmological examination. In case of spread to eye, up to 20, which happen in 25% of cases. And if it is untreated, it can cause blindness. So general management of catheter-related infection. So if once we have diagnosed that this is the catheter-related infection, then what next? So when denoting the duration of antimicrobial therapy, day 1 is the first day on which negative blood culture results are obtained. So vancomycin is recommended for empirical therapy in healthcare setting when elevated prevalence of methicillin-resistant Staphylococcus aureus is there. For institutions in which preponderance of MRSA isolate have vancomycin, minimum inhibitory concentration value of 12 mg per ml, the alternative agents such as daptomycin should be used. Linezolid should not be used for empirical therapy. That is for patients suspected but not proven to have CRBs. Empirical coverage for gram-negative bacilli should be based on local antimicrobial susceptibility data and the severity of disease. For example, fourth generation cephalosporin, carbapenem, beta-lactam is combination with or without aminoglyphosate. Empirical combination antibiotic coverage for MDR, such as Pseudomonas aeruginosa, should be used when CRBSI is suspected in neutropenic patients or severely ill patients with sepsis or patient known to be colonized with such a pathogen until the culture and susceptibility data are available and the de-escalation of antibiotic regimen can be done. In addition to the coverage for gram-positive organism, empirical therapy for suspected CRBSI involving femoral catheter in critically ill patients should include coverage for gram-negative and Candida species. Now, the empirical therapy for suspected catheter-related candidemia should be used for septic patient with any of following risk factors like total parenteral nutrition, prolonged use of broad spectrum antibiotic, hematological malignancy, recipient of the bone marrow solid organ transplant, femoral catheterization or colonization due to Candida species at multiple sites. For empirical treatment of suspected catheter-related candidemia, use echinocandin in selected patients and fluconazole. Fluconazole can be used for patients without ozone exposure in previous 3 months and in the healthcare setting where the risk of Candida krusei, Candida glabrata infection is very low. For means generally we are starting fluconazole if the patient is hemodynamically stable, and for hemodynamically unstable patient we are going for echinocandins. So this is the table which showed the empirical therapy that should be started. So if it is a low and moderate risk sepsis, then we should start with ticoplanin 400 mg BD for 3 doses, then 400 mg OD. Except for the patient on dialysis, then IV vancomycin. Alternative, if allergic to ticoplanin and vancomycin. Then high risk patient, ticoplanin 400 mg BD for 3 doses, then 400 mg OD plus temoxicillin. If a non-life threatening allergy to penicillin is there, or if non-life threatening infection is there, and if there is allergy to penicillin, then we can start with IV aztreonam 1 gram TDS plus ticoplanin 400 mg BD for 3 doses. If life-threatening allergy to penicillin, then IV ciprofloxacin 400 mg BD plus ticoplanin 400 mg BD for 3 doses plus 400 mg OD. In case of neutropenic infection also, we can start the coverage of ticoplanin plus piperacillin tazobactam. If non-life-threatening infection is there and if there is allergy to penicillin, then ticoplanin 400 mg BD for 3 doses, then 400 mg OD plus IV meropenem 1 gram DDS. Then for exit site infection, oral flucloxacillin 500 mg QID. If penicillin allergy is there, then we can use oral clarithromycin 500 mg BD or oral clindamycin 450 mg QID. Then when to use this antibiotic lock therapy? Antibiotic lock therapy should be used for catheter salvage. However, if antibiotic lock therapy cannot be used in this situation, systemic antibiotic should be administered through colonized catheter. 4 to 6 weeks of antibiotic therapy should be administered to patient with persistent fungemia or bacteremia after catheter removal. That is occurring 172 hours after catheter removal. There is a to patients who are found to have infective endocarditis or suppurative thrombophlebitis and to pediatric patients with osteomyelitis, 6 to 8 weeks of therapy should be used for the treatment of osteomyelitis in adults. Now, the long-term catheter should be removed from patient with CRBSI associated with any of the following conditions, like severe sepsis, suppurative thrombophlebitis, endocarditis, bloodstream infection that continues despite 172 hours of antimicrobial therapy to which infective microbes are susceptible, or infection due to Staphylococcus aureus, Pseudomonas aeruginosa, fungi, and mycobacteria. Short-term catheter should be removed from patient with CRBSI due to gram-negative bacillus, Staphylococcus aureus, enterococci, fungi, and mycobacteria. For a patient with the CRBSI for whom catheter salvage is attempted, additional blood culture should be obtained and catheter should be removed. If blood culture results, for example, two sets of blood culture obtained on given day, one set blood culture is acceptable for neonate. Remain positive when blood samples are obtained 72 hours after initiation of appropriate therapy. For long-term and short-term CRBSI, due to less virulent microbes, they are difficult to remove. Less virulent microbes that are difficult to eradicate, like Bacillus species, Micrococcus species, and the Propionibacter. Catheter should generally be removed after blood culture contamination is ruled out on the basis of multiple positive culture results, with at least one blood culture sample drawn from the peripheral vein. In uncomplicated CRBSI involving long-term catheter due to pathogen other than Staphylococcus aureus, Pseudomonas aeruginosa, Bacillus species, Micrococcus species, and the Propionibacteria, fungi, and or Mycobacteria, because of the limited access site in many patients who require long-term intravascular access for survival. For example, patient undergoing hemodialysis or with short gut syndrome. Treatment should be attempted without catheter removal with use of both systemic and antimicrobial lock therapy. After a positive blood culture is reported that may represent CRBSI, automated standardized treatment advice can be formulated to improve compliance with Infectious Disease Society of American guidelines. Then urokinase and other thrombolytic agents are not recommended as an adjunctive therapy for patients with CRBSI. If catheterized patient has a single positive blood culture that grows coagulase negative Staphylococcus aureus species, the additional cultures of the blood sample obtained through suspected catheter or from the peripheral vein should be performed before the initiation of antimicrobial therapy and or catheter removal to be certain that patient has true bloodstream infection and that catheter is likely the source. Now this is the table which showed the treatment approach for confirmed CRBSA. So if it is a complicated infection, that means if it is involving suppurative thrombophlebitis, endocarditis, osteomyelitis, then we have to remove the catheter and treat the systemic antibiotic for 4 to 6 weeks, 6 to 8 weeks for osteomyelitis in adult. If it is an uncomplicated infection, which is a bloodstream infection, and fever resolves within 72 hours in patient who has no intravascular hardware, no evidence of endocarditis, suppurative thrombophlebitis, and for Staphylococcus aureus is also without active malignancy and immunosuppression. Then, if isolated organism is coagulase negative staphylococcus, then remove catheter, treat the systemic antibiotic for 24 to 48 hours. If catheter is retained, treat with systemic antibiotic and antibiotic lock therapy for 10 to 14 days. If isolated organism is staphylococcus aureus, then remove catheter and treat with systemic antibiotic for more than or equal to 14 days. If isolated organism is enterococcus, remove catheter, treat with systemic antibiotic for 7 to 14 days. If gram-negative organism, then remove the catheter and treat the systemic antibiotic for 7 to 14 days. If we are isolating candida, then also we need to remove catheter and treat with appropriate antifungal therapy at least for 14 days. Thank you.